Good day. My name is Stefania Martignon. I am a professor at Universidad del Bosque and chair the UNICA, the Caries Research Unit in Bogotá, Colombia. I also chair the Colombian chapter of the ACFF and sit in the global panel of the ACFF. I'm a board member of the ICDAS Foundation and the executive chair of CariesCare International. I would very much like to present you Caries OUT case study, CariesCare International adapted for the pandemic. What is CariesCare International? It is a patient-centered, risk-based approach to caries management that has been designed specifically for the practice. It comprises a health outcomes focused system which aims to maintain oral health and preserve tooth structure at the long term. With this 4D cycle structure, it shares same goals as ICCMS related to preventing new lesions from happening and preventing the progression of existing lesions, either with non-operative or operative care, and in the meantime, managing also the caries risk at the individual level. In September 2019, we published the CariesCare Practice Guide with 47 experts from the world, and this has not yet been tested. So at the end of 2019, we planned a 1-year effectiveness of CariesCare International caries management in 6 to 8-year-old children, multicentre RCT. 21 centers in 13 countries agreed to participate. The control was going to be in each center, the local system they were using. Here you can see the leader team and the different countries and universities with their leaders. So, to understand a little bit more about the 4D structure of CariesCare, it has these 4 Ds, as you can see here, and we will go one after the other. The first one is determine the caries risk, and it deals with an interview asking about protective and risk factors, which includes social medical behavior and clinical factors. Then it moves to the intraoral assessment, 2D, to detect and assess caries lesions. And for this, we use the ICDAS merged criteria. And if possible, we include x-rays, and we also assess the activity of the caries lesions. With the information from 1D and 2D, we pass to the 3D, which is deciding the personalized care plan, both at the individual level with the caries risk management, also deciding when to recall the patient, and at the tooth surface level, according to the status of the surfaces. And then we move to 4D, preventive and tooth preserving care. It is the do 4D cycle. And this includes both at the patient and at the tooth surface level. So in 2020, we got the grant from the University del Bosque to participate in this project, at least to set it up, not for the whole multicenter study, but yes, to set it up. And then in February, we got the Institutional Ethical Committee approval. The outcomes are related, or were related, to tooth surface level caries progression control, and secondary outcomes also taking into account the lesions, the caries risk level, avoiding extractions, pain, and failure of fillings or sealants. Also, we included behavior change in children, acceptability of parents and dentists, and exploration of costs. The sample size was of 516, and this was going to be achieved with 40 per center. So we were going to have, of course, even more than that. But then COVID arrived, and there was a lot of uncertainty. In the meantime, we were already advancing with CCI e-learning, which we designed and developed both in Spanish and English on how to implement CariesCare International in the dental practice. And we continued doing this. This e-learning was composed of 5 modules, as you can see here. In March, it was launched in English, in May in Spanish, and you can do it in approximately 40 minutes. It's definitely for the clinical practice, and it sends you through each of the modules to see the different cycles of the 4D. So, what else happened when we were already starting the pandemic? We got the approval from the IADR Regional Development Program for Latin American Fund or grant for these 13 centers in 7 Latin American countries. And this really got us thinking because, of course, each of the center had stopped the project when we started the pandemic. But this led us to think a lot because we already had many advances, what we should do with it. So we started having meetings with the different parties, first, of course, with the leading team, and then with the other centers to decide what to do during this pandemic phase. And we thought about modifying the study. So, taking into account this hierarchy of controls, we could see that we could work with a non-AGP, non-aerosol generating procedures, and reducing in-office time care. And then we decided to change the aim of our study to this one, to assess in a single intervention group in 3 to 5 and 6 to 8 years old children, the caries control effectiveness of CCI adapted for the pandemic with non-AGP and reducing in-office time. The parts in red are the changes that we introduced, and the sample size was halved to be 30 per center. And all the centers agreed to continue participating in this study. So what would be the differences? This was the scheme we had for CariesCare. The modifications regarding the pandemic were to be, as you can see in the next slide, this. For the first D, we included oral health behaviors, assessment and management, both oral hygiene and dietary habits. We were going to try to do most of this remotely, and we were finding a way to classify it automatically through an Excel form. In the second D, we were not going to use air nor radiographs, so we went for ICDAS EPI, which is used in these cases. And then in the 3D and the 4D, we only plan to do activities with which didn't involve aerosol generating procedures, and we tried to conduct as many as possible activities with remote. So in the do, you can see here that we were including the short behavior change tool, focusing on oral hygiene and dietary habits. We were going to use only ART sealants if these were necessary, for example. Then at the tooth surface level management, as we were not going to use any aerosol generating procedures, here you can see that we were using sodium fluoride, SDF, and ART sealants for non-operative care, and for operative care, whole technique and ART, whole technique only in primary teeth. And here you can see some of the examples and the doctors who have facilitated them. The outcomes were the same, but they were different because the sample was different. This was not anymore an RCT, but it was approved by the centers to work in this manner because we still wanted to test the CCI system, and we also wanted to have a solution for the children who had caries lesions. So the parties agreed to move forward. This was the new title of the study. We register it in clinicaltrials.gov, and here you can see the same authors. Those in red also are related to the ACFF, either in the UK or in Colombia, or also in the Caribbean. So these are the 21 centers in the 13 countries that agreed to continue with this modified Caries OUT study. And we were very happy for that. In addition, in June, we got the modified IRB from our university, El Bosque, and IADR, the Regional Development Program for Latin America, was also happy to fund the modified version of the project. So we started with more advances. After the first e-learning, we conducted a second e-learning, which was related to how to achieve caries management in children, minimizing these aerosol generating procedures and on-site appointments. And this was part also of a project with a young researcher. So it involved the Colombian Government Institution for Research. It is only one model, and it has a duration of 28 minutes. It was also done in Spanish and in English. And these all have been uploaded in the CariesCare International website. We have the training and forms and tools designed. So we had at least 2 4-hour workshops, both with the Spanish-speaking centers and with the non-Spanish, which were in English in our case. And we designed all the material, all the forms in both Spanish and English. Here you can see the oral health record, which was designed in an Excel form. You can see the first D, and this was automatically deciding in the third D the risk of the patient because you were feeding it with the information. Here is the second D, and here you had the opportunity to assess caries and other conditions as well, and also plaque. And in the third D, this was going to take from these tooth surfaces the decision if it needed non-operative or operative care, and regarding the caries risk, if it was high or low, and when the patient should be seen after the basic management was done. For the 4D, regarding these decisions at the tooth surface level, here you would have the opportunity to specifically define if you were going to conduct ART or whole technique, etc. And at the patient level, the management of the risk and also of the behavior. And this oral health record is now being part of the oral health record software prototype, which is one of the advances for the future of this study. With Professor Tim Newton, we work on this CCI short toothbrushing dietary habits behavior change tool, taking into account the GPS core principles of the COMBI model. And again, in the 4D, you can see that we, in the first D, determined the behaviors, taking into account also the diet with this form that we designed or diagram. In the second D, we had to assess if the patient had caries or plaque. And then this would automatically classify the behavior of the patient for these two aspects. And then in the 4D, we would manage them, taking into account prompts and also self-assessment and online appointments. And then we also decided when the patient was going to be recalled after the basic management was finished. Okay, so other aspects that we have so far advanced in, the e-learning, and this first column shows up to last January, the statistics in English and in Spanish. And basically you can see that it has been used up to January for over 600 persons and around 35 to 40 minutes. So it has been conducted. And figures that are up to May 2021 for English and Spanish show that for the English version, it has like 500 new visits at that time. For the Spanish one, 1,400. And here you can see the peak moments. In the English version, it was April last year and March this year. For the Spanish, November last year and April this year. We have also been able to publish the protocol in BMC Oral Health in the first term of this year with all the participants. And we have been able to have a symposium just for this Caries Out with the participation of the leader team and also other researchers and other also persons from the Ministry of Health in Colombia, which was very important for us. We have also reported it in ORCA with regards to the education tools, and in the IADR we had a symposium, and here you can see the persons who participated in showing these and presenting this symposium. So these are the 21 participating centers in 13 countries. And for each country, you can see in yellow if it has already started. Basically, 15 centers have already been able to start. All of the centers in Latin America region, regarding Latin America IADR region, have started. The considered North American, which are Mexico and the two in the United States, have not yet started. And then in Europe, France has started with University Côte d'Azur, the Moscow University as well, and we are still waiting for the others. And here again, you can see the numbers of the different leaders. So this is also some examples of the participating centers. showing how they have been doing it and the difficulties, of course, of working with the children with all these PPE. And here you can see, as an example, the forms translated into Russian, which has been something that countries have needed to do, also to other languages, of course. With regards to the challengers, we have had biosafety regulation and government guidelines imposed during the pandemic period in each country. We have had delays generated due to administrative and logistics adaptation processes. We also have had parents and participants feared to contagious upon returning to the clinic. Participants drop out related to this, and then also quarantines, isolation related to the SARS-CoV-2, and high costs of supplies in each of the centers. The centers that have not started relate these to the IRB. They have not been able to conduct clinical studies yet, and also national restrictions, research restrictions, or they were not yet all vaccinated. Here you can see also an example of the barriers and the facilitators that have been presented in Latin America. And as facilitators, they say that they have learned a lot, and also that we have been able to have loads of meetings which have facilitated things. As barriers, the costs are also a barrier because they have increased and each center is funding itself. And here you can see some of the authors from or leaders from each of the centers, and we can conclude this study or this clinical case study that it has been a challenge in terms of biosafety, costs, adherence, and pandemic aspects. Strategies implemented to overcome these challenges have allowed the generation of experiences that can enrich the dental care in times of COVID-19, as well as learning, networking, contributing, and teamwork opportunities. And I would like to finish by acknowledging the different parties. So Única and Universidad del Bosque for the study design and managing, and the learnings development. Other leader universities from King's College London, University of Leeds, and University of Sheffield for their contribution time. The IADR RDP LAR program for promoting research in Latin America. The ACFF Colombian chapter is funding partially the e-learnings and the printing of the didactic aids, and also the Colombian Center. The Global Collaboratory for Caries Management uploaded the e-learnings in the CCI website and is supporting CariesCare International. And of course, the 20 dental schools, universities, and one health provider who are funding each center study, setting and developing it, and all persons and patients involved. Thank you very much for your attention.